Okay, should be. We'll see how this goes.
Great. It says we're now streaming on Livebook.
Good. Can you guys hear me?
Yes.
Okay. Good. So let's get this started. Welcome. My name is Kevin Fitz, and I am here with three colleagues of mine, and we want to talk about Oregon Legislative Session 2021. And we have 3 or 4 bills that I'm going to talk about, and then our co-host Laura Rose will bring up some bills, and then maybe we'll have a sort of ongoing discussion about some other bills and some background about some of these bills particularly. My name is Kevin Fitz. I'm a volunteer with the Oregon Mental Health Consumers Association, and I'm glad to be here. And Laura, why don't you introduce yourself?
I'm Laura Rose, and I'm current chair of the Oregon Consumer Advisory Council, and I serve on other work groups, and I'm a consultant and a consumer and family advocate. Glad to be here today. We also have with us Janie and Drake. Would you like to introduce yourselves?
Sure. Hi, everyone. Janie Gullickson. I am a person in recovery. I'm also the executive director of the Mental Health and Addiction Association of Oregon. And I'm here to learn as well as participate in some of this discussion. Looking forward to it. Thanks, Laura Rose. Thanks, Kevin. Thanks, Drake.
Thank you. And Drake, would you like to introduce yourself?
Yes, I'm Drake Eubank from Eugene, Oregon, and how would I describe myself? I'm a person in retirement who has enough time on my hands to take a close look at what the legislature is doing and be pretty interested in the new versions of the same old abridgment of our rights. But I'm generally a consumer and advocate for about 45 years of my life. Thank you.
Great. Thank you, everyone. So Kevin, where do you want to begin?
So why don't we give just a brief understanding about what the Oregon legislature is? Why is that? Also, let me say, we titled this Oregon Legislative Discussion 2021. But for those who know me and know some of the other people on this video, most of us work in the intersection between public policy, behavioral health services, peer support services, and consumer leadership. And so this will be particularly a focus of looking at bills that impact behavioral health, substance use disorder, foster children, suicide, and some voluntary intermediate supports for people in psych crisis. So that is kind of the focus of this. So Laura Rose, why don't you tell us what the Oregon legislature is and why, for somebody who's a mental health consumer or works in as a peer support group, why the Oregon legislature is important.
Great. Well, our Oregon legislature is the legislative branch in our state government in the state of Oregon. And the legislature is a really important decision-making body, both on public policy and on budgeting, a lot of leadership for our state. So one of the things I love to say about the legislature is that they can pierce the bureaucracy. So sometimes, we get stuck in a situation with maybe an agency, part of the administration, and there's so many layers of red tape and forms and departments and divisions and all of that. And when we have a real crisis or a real emergency, something that needs to be addressed, sometimes we can engage our representatives on the legislature to help us They have staff and they have teams and they have a lot of knowledge about how things work. And as one legislator told me, we hold the purse strings. We can put the whole agency budget on pause, if it comes down to it. So that gave them, a certain level of authority and power to make sure they could get answers, as needed in a timely fashion. So there's a lot of work that they do collectively, and they can also help you individually. So we have the House and the Senate. We have the House of Representatives, and I think that's 60 legislators. And then we have the Senate with 30 legislators. Is that correct, Kevin? So help you individually. Yeah. So we have the House and the. You might want to mute. There you go. And so there's a lot of reasons why it's really crucial to be involved with the legislature. The policies that become part of our culture, they have a big impact on our lives. The rules, how things are done, the laws, that sort of thing. It also guides and determines programs that get funded. So that's important. And anyway, there's a lot of function. Our state is running on a 2-year budget. So we usually go from July 1st to June 30th, 2 years later. And so this year we have the legislative session that starts this month in January 2021. That's going to be hopefully closing up in June 2021, maybe July 2021. And so starting in July, is going to be another 2-year budget for our state. So it's really important they come to decisions at the end of this legislative session in June or July, and that's what's going to be in place for the next 2 years. Now, in the intermediate, next January is another legislative session. That's a short session, usually that takes care of some emergency matters and might make adjustments. But the majority of the work that's done on budget and policy happens during this longer session. And here we are in 2021 at the start of it.
Very good. Thank you. I put in there, do you mind if I share the screen? So why don't we start talking about, Drake, are you with us still?
My connection goes in and out at times, but generally, yes.
Okay. I'm gonna share these two bills, SB 187, or what was it? SB 187 and SB 189, and I'm gonna share those in our thing here. And Laura, can you read the summary statement for SB 187? Can you see that in there? Okay.
I do. So it says defines dangerous to self or others for the purpose of taking person with mental illness into custody. That's the catchline summary. And it looks like it was it says filed by order of the President of the Senate in conformance with pre-session filing rules, indicating neither advocacy nor opposition on the part of the Senate President.
Okay, very good. So that's SB 187. Can now you see SB 189, Senate Bill 189? You want to read that too?
Senate Bill 189, its summary says requires outpatient care as condition for trial visit of person committed to custody of Oregon Health Authority as a person with mental illness.
Very good. So welcome, Drake Eubank. You are an individual who has been somewhat involved with this committee. The committee put together by Senator Floyd Przansky and a judge in Eastern or Southern Oregon named Wolke, Judge Wolke, put together a work group called the Work Group to Decriminalize Mental Illness. Why don't you take a few minutes and tell us about that and your experience and some feedback about that, and then we'll go in sort of a discussion of, what these bills purport to do.
Well, like the issue of the political correctness of the terminology being wrong, first thing they did was call it mental illness. Second of all, the decriminalization part seems to recognize a distinction between having somebody locked up and drugged or drugged in the community under the authority of what is essentially a parole office for mental health, and doesn't seem to recognize the restrictive elements that sort of run in parallel with the criminal justice system, even though they think the difference is that there's treatment available, which some people
What
have
was
some
the
questions even about
impetus?
that.
What was
Anyways,
what
the
was impetus of this work
Judge
group?
Wolke was frustrated with the lack of options for people that were either acting out and what he thought would be quote unquote crazy and not being preemptively punished by or directed by the courts. It's essentially working on an agenda that was brought in by the Treatment Advocacy Center, which is a rather questionable organization, a fairly authoritarian-based lobby around things like Kendra's Law and a lot of forced treatment, a lot of assertive community treatment, which means basically being mandated in the community. And Bulkey invited those people onto the committee, got Prozansky to buy into it around the hysteria that's created around people that are causing problems, and there must be some way to deal with this. A lot of frustrated parents who couldn't control their children, and so this committee has met repeatedly without and has come up with previous bills, and it met repeatedly without benefit of more than 2 consumers out of about 30 members. And now there's an auxiliary committee that David Oakes runs called Consumer Voice Subcommittee that is trying to articulate the user experience in light of the kinds of legislative efforts, of which this is one on which we had literally no impact on whatsoever. So just so you know.
Drake, what do you mean by mandated in the community? What do you mean by that?
The assertive community treatment model, I think they call, somebody will have to help me on the official name for it. My memory is lapsing, but it essentially is a mode of treatment that in milder cases is a voluntary interaction with the mental health system once somebody has been committed or deemed mentally ill under one of these statutes. So instead of interpreting the law that way, they more or less mandate treatment and usually force drugging in the community. Instead of keeping the person locked up in the hospital, they exit them into programs, or they keep them in the community in programs that essentially act like hospitals without walls or prisons without walls for those that are more into the civil liberties aspect. So they can mandate treatment, anything from invasive chemicals to going with programs. And I think my background noise is gonna drown me out here, so I don't know if you guys can hear me. But essentially it's mandating treatment that is not a choice of the consumer in the community, instead as an alternative to just letting the person go back out or even be treated as a normal person with normal civil rights. And you guys catch that?
Yeah. So Laura, Janie, so this stuff seems to be on the rise in many state legislatures across the nation. Where is the particular voice of the peer and the consumer? Because a lot of this is a civil rights issue, the ability to forecast way in the future whether or not you're going to have a severe mental and emotional break, the ability to hold you, detain you for observation beyond 3 to 5 days and move that, into 2 weeks or something. But why is this moving forward if so many consumers and so many people in the peer world find this an abrogation of their civil rights as a human being?
Is that directed towards somebody?
Janie or Laura?
I think, or more, I wonder, if it's just, as Drake said, family members, parents, in the community that don't know that there are um, other alternatives, other solutions, other options, and it's this desperation, or even on the milder side, discomfort when other people experience different realities or express themselves in a way that makes society uncomfortable. And I also heard this, goes from discomfort to panic, like, oh no, they're dangerous, and this just global stigma that has been put on us for too long when we experience things that make people feel uncomfortable. And it's more about them than it is about us, because what I don't hear is things that or solutions that that are long lasting or benefit the person that they're trying to serve or mandate or control. I hear a lot of in the moment. I think medication has always just been this first line of defense, and it's really tranquilization. Sometimes, sure, as a person who is in extreme crisis, maybe in the moment, that was helpful, but longer term, I would just become a tranquilized, very compliant person, not making anyone else uncomfortable. But what kind of life would that lead me? So I know civil rights and having our civil rights honored is number one. And then also, what are the solutions we would like to see? And that's what I'd like to hear from you all as well. I mean, what are some ideas that we can put forth? And then how do we collectively get those ideas put into practice rather than just the status quo?
Yeah. Laura, do you have any thoughts? It seems to me that that on the side of this, there is everybody else in the world, and then a few civil rights attorneys, and then some mental health consumers on the other side of it, and everybody else pushing for conservative, draconian interventions into their choice and to their healthcare. Go ahead, Laura.
Well, one of the things that comes up for me as Janie was sharing, there's the medical model, and then we talked about alternatives and the social justice model. So, some of the reasons why people are having mental health crises and breakdown have to do with basic survival. How hard is it to find a job that's steady, that is flexible? Fortunately, there are some programs like supported employment, or, the ADA, the Americans with Disabilities Act, has brought us a long way towards having more accommodation. So, people may need a flexible schedule. They may need, different, they may need time to go to their appointments or whatever, and so, there's a lot of issues, job employment being one of them, housing being another one that's really important. How do we help people with housing? There's programs out there like Housing First that say if you provide the person the stability of a safe, warm place to sleep, then you can start to build the other things in your life that help you, have a quality of life and be more active and engaged and heal if you have trauma to heal from. There's so many important factors that go into it. And, but if they just put people on, these heavy medications for tranquilizers or sedation for long periods of time, there's a lot of effects, even the shortening of life. There's certain studies that say the persons with mental health diagnoses end up living up to 25 years shorter. That in large part I think for many has to do with the long-term side effects of some of the medications. I have friends in my people in my community that have, you know, been put on up to 8 medications at a time, and it's completely blown out their liver, or they've ended up with kidney failure. They've had to either go on a waiting list for a transplant, and some of them didn't make it in time. And so it's tragic, you know, the loss that can happen. So we know that sometimes, you know, for, you know, medication may be good in a short term, but it may not be good in the long term. And that's not to say, you know, it's a very individual thing. For some people that may work longer term, for some people not, but we have to have options for those that it doesn't. And we really want a quality of life opportunity to reverse, you know, the trend and help them. And so, you know, that's the removal of civil rights, you know, at what cost? And are we looking at what are we doing as a society? How are we responsible for one another, for supporting one another's health and success, support, you know, through peer support and everything? If we're not looking at those questions and we're just focusing everything on this individual's not behaving in the way we want to see them behave, or, you know, they're sleeping in front of stores on the street. And I just feel like people keep ignoring the needs of others, and it's just a cascading downhill. And now with uncontrollable things like the pandemic and the wildfires, that's only accelerated houselessness for so many displaced in our communities. I am pleased to see many in the legislature standing up and taking a look and bringing this in as an emergency. We have to address these situations. We have to reform healthcare. So there's some positive trends, but then we have some of these bills that look like, you know, it's going to bring about the approach like Drake's been sharing and talking about, that's not so, I don't know, I would say humane is a piece of it, and justice oriented. Anyway, those are some of my thoughts.
Thank you. So Drake, tell us a little bit more. So the work group that was populated by consumers and survivors and peers completely objected to these 2 bills in their language currently moving forward, but they are moving forward, and now they're slated to potentially have a hearing in the Oregon State Legislature in the next 3 or 4 weeks. What happened to the voice of the consumers, survivor, and peers on that work group?
Can you hear me?
Yeah.
Okay. The basic information is we were the subcommittee, which we were not included in the full committee itself, but they did take the legislative aid and assign them to our meetings, which is something. Her name is Chana Newell. Anyways, we were, I think if you could have them make a broad assessment, as we were simply gaslighted out of our concerns. I mean, they basically said that we have anagosia. I think that basically no insight into what it really took to deal with these conditions that we all had.
Does that mean in a nutshell, you're suffering so much from a mental health challenge that you don't even know that you're suffering from a mental health challenge?
You lack judgment as to the reality.
Agnosania is the term.
I could never pronounce it right, so thank you, Laura.
Yeah, it's being.
And that was actually a big term in the hearings on the Murphy bill, which is one of the things that is funding.
Oh,
by
yeah.
the way, there's funding attached to forming these community-based forced treatment regimes in the states. They will be able to access federal funds in order to finance basically drugging people in their homes. And that bill, in particular, Fuller Torrey and other people from the Treatment Advocacy Center testified in favor of adding forced treatment essentially to community-based care in all the states, or at least incentivizing it. In this case, they couldn't mandate it.
Right, and the names that you're mentioning, like Fuller, Torrey, Murphy, those are people on the federal level in Congress, right? And or
Fuller Torrey actually is the leader of the organization that has a lobbyist on the committee, the Treatment Advocacy Center, which was people that were too radical for NAMI. And so they lit out and have been pushing really hard for people to be, creating legislation that is more and more restrictive, more and more mandating treatment. And there's two basic problems with that. One, that the people's civil liberties are messed up pretty badly. The treatments themselves are not exactly healthy. You were mentioning about the science of it. 4 out of every 10 people that dies early in the studies, the causes are directly related to the medications they give people. And then any other population group, if we were Black or, part of some other element, it would be almost genocidal to, essentially assess how the impacts of the treatments cause health, not just health problems, with lethality. And that's
Very
not
good.
even counting the other ones. Sorry. Anyways, I need to just finish the piece that you asked me.
Yeah, go ahead.
We
go ahead.
were completely cut out, but that's kind of the purpose of the committee. Wolke has been strongly in control of it, and Prozansky has kind of gone. The senator has kind of gone along with his kind of gerrymandering of things, and not being listened to has to do with the agenda, which is basically to find a way to force people into treatment when they can't just simply get them into treatment voluntarily, or otherwise. I mean, something that I'm in favor of, just letting civil rights operate normally under our laws. If somebody's threatened someone or done something like that, they're available to be processed first in the criminal justice system, and then they're totally welcome to opt out into other modalities of diverted into mental health care if that's what they want. It's just this preemptive, like, you might be dangerous, and this is what's in the current laws. If you might be dangerous, or have ever done anything in your life that might be considered threatening to anybody, even if you weren't mentally ill at the time, can be considered in locking you up for an indeterminate amount of time, as far as I can tell.
Very good. Okay, well, we should probably, we spent 15 minutes on those. Let's move on to bill number, and this is, let me bring this bill up here real quickly. And so this bill was introduced by Senator Lou Frederick. I'm going to share the screen, and when I do, so let me share the screen. So Laura Rose, you want to read the summary to this and give us a little background on healing choice and what this means particularly?
Sure. So there's this bill, Senate Bill 686. It establishes the right to receive inpatient psychiatric care. Oops, you went back. Kevin, can you change your screen? You went back.
Oh, sorry.
There we go. So establishes the right to receive inpatient care in person and on site. And so I've heard Ann Casper, one of our peers, speak about this topic. There was concern, as through the pandemic, one of the things that we've seen is the use of telehealth, where you have a remote appointment, you're talking to somebody like we are today with one another through video and audio. And so, but if somebody is in the hospital receiving mental health care in an inpatient psychiatric unit, as it describes, there's a desire that they would actually be able to speak directly to an individual, and I believe opt out of sort of the telehealth approach, but be able to be present and be heard and have conversation on site. And so, let's see. So Ann Casper gave us a couple of bits of information. She wishes she could be here today with us, but she said there is a website that's coming online, choiceheals.com, and that's choice, CHOICEHEALS.com, Choice Heals. And they're going to be requesting stories from people on this topic that they can take to the legislature. So if you're interested, it would be good to get in touch with Ann Casper, and hopefully they have contact information on their website, choiceheals.com.
So let me ask you a question. So this gives the patient the choice to either have telecare or an in-person contact with a therapist or a psychiatrist or a mental health professional. Is that right?
I haven't looked deep at the text. Why don't you click on the text and pull the text of the bill up, and we'll take a quick look. So here's the text. It looks like it's a one-pager, so it's not too long. What they've put in here, shall have the right to have the psychiatric care provided to the individual in person and on site, and to refuse to receive psychiatric care through electronic means from a psychiatrist or another mental health care provider who is not on the premises. And then there's another section of it, similar. It says both for the initial evaluation and ongoing treatment, prescribing of medications, and conducting of assessments, particularly or evaluations in civil commitment proceedings or in other circumstances requiring the evaluation of mental competency. So I believe that's saying they don't want to have remote assessments done without someone being there in person. I can imagine quite a few reasons for that, but I think Anne will be able to say a lot more on this.
Yeah. So this would apply to the Oregon State Hospital system run by the state of Oregon, and also the Unity Psychiatric Legacy Hospital, all of Providence, Cedar Hills. I was told by a person who was in Unity Psychiatric Crisis Hospital, and they were there on a Saturday, and they rolled in a TV set to get a consultation by a psychiatrist who was in Florida at the time. No, but the patient, my friend, was not told that that was going to be the consult, that you were going to be talking to somebody in Florida about your mental health issues, and that was abrupt, and they were uncomfortable with such a thing. One of the other things.
Example, really quick.
Go ahead. Yeah.
Yeah. So one example, I know somebody that they spoke on the phone with a psychiatrist for less than 15 minutes. This psychiatrist did not have their records, didn't know their history, and in less than 15 minutes was ready to go and write an order for this person to receive the electroconvulsive therapy treatment, ECT, which for many people, a few people I talked to say that that's, been a breakthrough for their suicidal depression. However, for many more people that I've talked to, the effects of it impairs their memory. It makes it difficult to function. They might come away from there and not remember their family members. It can really do a number on somebody's memory, that has really significant impact. And to think that somebody has not even looked at your records, only talked to you for 15 minutes, and that's, who knows if they're listening or if they're doing the talking, that's a short time for such a, and the effects of that can be months and months, if not years. And so, a big decision, I think those decisions are so important. They need to be made with, special attention and quality service. So I think that's one aspect. I think if you're not with the person in person, a lot of people would have trouble talking about their trauma history, or, whatever is relevant to the conversation about their treatment that might inform that, if it's a cold and distant relationship. And also if you're not working with local providers, there's a sense of what is their stake in your outcome. If they're a member of your community, they have a higher stake in seeing you well. If they're at a distance and, they don't know you and they might never see you again, is there accountability? Do they really have that same connection? I mean, so there's a couple, kind of human factors like that I'm sure were in mind when this bill was proposed.
Yeah.
We'll see where it goes.
Yeah. So Janie, you must, since COVID, an awful lot of stuff has moved into the digital sort of area. What is the sort of sentiment from, all the peer support workers that you employ and their outreach and connection through digital and telehealth means? I should say that me individually, that I think that there is some convenience and accessibility for telehealth sometimes when there's not providers around in certain areas. I know we have a huge shortage, according to the child psychiatrists that I know. There's a huge shortage of child psychiatrists in Eastern Oregon and some of our rural areas. But as a principle, I like the idea generally that if you're getting a psychiatric assessment or someone's going to be prescribing you medications, that they would have somebody there in front of you. But what do you think?
Yeah, thanks, Kevin, and I appreciate the comments that you made, Laura Rose, as well. I think for the peers at MHAAO, there was that initial COVID, everyone is sort of got to protect ourselves from this illness we know nothing about that's so contagious, and and also the powers that be are shutting everything down and saying that we can't access or provide services in the way that we had. So in the beginning, it was amazing to see how especially the peer workforce just responded with, hey, let's do this by telephone or over Zoom or FaceTime, however we can do it. But then I think there was a shift after a while in thought, because we were seeing it's not the same, especially when you don't have an established relationship that you had built in person. I think even in physical healthcare, it was nice to have the convenience of virtual appointments, but it would have been a totally different experience if I didn't know my doctor and hadn't already built that relationship in person with them. And so, some hybrid model is great, but there's something to be said about being in the same space with that person, seeing the nuances in their reaction, or knowing that they're listening fully, or not. You can tell when they're not too, when you're in person. And that ability to feel genuinely heard and not just part of the line of cattle, like next. And so the options to, especially when establishing
Sorry, line of cattle, that's an interesting euphemism. Go ahead. Yeah.
I just see them all being pushed through the gate.
So let me ask you another, so sort of mining this a little bit. So the question of how many peer support specialists do you employ at the Mental Health Addiction Association of Oregon?
Well, organization-wide, there's 65 of us, and we all have, some form of lived experience. But the direct service peers, there's over 30 at this point. Yeah, maybe closer to 40. There's been a lot of growth during COVID as well, and a willingness to go out there and meet people in person. And I think that's been unique to peer services, just getting out there and taking all the precautions, doing what we have to do, but recognizing the value of being human to human in the same 6 feet of space.
So all those people's lives that your peer support team touches, if they had to weigh in about SB 686 and saying we'd like to have a choice, and when we're in the psychiatric hospital around either a digital interface or having a live person there, or having it being a hybrid of actually having a person next to you. Sorry, the mail came. What do you think the sentiment would be around this? I really support this bill, just because the idea of consumer choice is so railroaded and owned by industry and other people who have other agendas. but I fear that the hospital association and that the people that run, the state hospital are going to come out against it because the efficiency, the convenience, and the and the affordability.
Workforce shortage.
Yeah, workforce shortage. Yeah.
Definitely going to on Tuesday reach out to all the staff at my organization and maybe even beyond, trying to get the opinion of the peer workforce on this Senate bill, because thank you for sharing it through the busyness of the day. I didn't know much about these bills, and so I'm glad you're putting on this
You just
platform.
got their number 2 days ago.
Oh, God. Okay, well, good. I don't feel so far behind, but we need these platforms to inform us, because if we are out there doing the work, we sure appreciate those that are doing the work of learning and then educating us on the advocacy and political side of things. So,
Are you on OPLAT?
yeah.
Janie, are you on OPLAT?
Yes, and I appreciate those emails.
So OPLAT is our Oregon Peer Legislative Action Team. Megan Cahay, Ann Casper, Kevin Fitz, Jack Hodchek, quite a few people in the community got together and talked about it, had a few meetings several legislative sessions ago, and then we decided to start the mailing list. And we also have a Facebook page. That's Oregon Peer Legislative Action Team. If you're not on it, please get on it. That would be great. The email address we can post in chat. It's oplat@unitedvoiceforchange.org. OPLAT. And then, or you can search it on Facebook, OPLAT, and request to join. That's where we post updates that are related to Oregon state legislation information, especially for our peers and our peer communities, peer-run organizations. We also have an NPLAT and a GPLAT.
Laura, say the email again for OPLAT.
OPLAT.
Yep.
At unitedvoiceforchange.org. ORG.
Great.
Yeah. So one of the things I try to do at the beginning of each legislative session, thanks, Janie, I try to really make sure that there's kind of a list of bills to pay attention to in our community and that we have dialogue around those. And then when certain legislative hearings come up, if we know about them ahead of time, we try to get you the key information so you can participate. And there will be a lot that's having to happen through video this particular legislative session. Unlike in the past, we've had lobby days where people can go on certain days and the legislature is having hearings on certain topics. And so people talk to their legislators in person. But with everything that's going on right now, it looks like that's going to have to happen over video. And we'll talk about that more maybe in another session. Thank you.
Very good. Laura, do you have a bill that we could bring up and spotlight at this time? I want to talk about the governor's bill, but I'd like to do that a little bit later on. And it'd be great to have a conversation with you and Janie, because I know you all both served on work groups of that. But did you have a few that we could bring up? And just want to, it's 1:45, so hopefully we got about, I don't know, an hour left, hour 15 minutes left. But do you have one you want to bring up and I could bring it up and share the screen with it?
Sure. I think before you do that, though, I'll just make a quick statement, sort of a few initial scans of the multitudes of legislative bills that are already in the hopper or whatever for this legislative session. I've seen definitely some sort of themes, if you will. There's quite a few bills with updated language. So they're using SUD, substance use disorder. There's another bill about replacing terminology. Do you remember that one, Kevin? Mentally defective is
right,
Senate Bill 566. And then as Drake shared with us, even Senate Bill 187, where they're defining what they consider dangerous to health. and whether that includes all past behavior of any kind. It looked very broad, which is really concerning. So, so anyway, so there was that. There's others about expanding protection, and some about expanding accessibility. There's a bill that's on the topic of interpretation, that interpretation services should be offered, in particular interpretation, like American Sign Language for people that are either experiencing deaf or hardness of hearing. That's in there. And some other ones about making sure that if there's a disaster, an emergency, that organizations have a plan in place for how to help people be able to exit the building and those kinds of things, both for elders and for people with disabilities. That one is SB 434. So there'll be an email going out with these. And then Kevin maintains a list of bills of interest. There's a great tool. Anybody can use it for free to monitor up to, I think, 25 bills. It lets you search the bills by text, by names, keywords. And so I go in there sometimes and look at bills that are on a certain topic, like mental health, and it'll come up. And I was surprised this year, absolutely pages and pages and pages of bills that either have the term psychiatric or mental or suicide. There were 12 bills just on suicide alone. Now, suicide's one of the topics that's close to my heart, suicide prevention. And so there's a few bills this session. Let's look at HB 2381.
HB, okay, so HB
2381. Yeah. And while you're bringing that one up, there's a bill also on the Senate side, Senate Bill 563. So sometimes when people introduce bills, they'll introduce one in both the House of Representatives and the Senate. It's kind of like then you have two chances for a bill to move out of committee. People may or may not be familiar with the legislative committees, but there's so much work on so many topics that in order to have effective discussions on policy making, the legislature puts a lot of power in its committees. So there's committees that are under the House and there's committees that are under the Senate. And so those committees are specific topics, usually like health and human services, labor, workforce, environmental, housing, things like that.
Each year, Laura, let me interrupt. Did you say 2831 or 2381? This one is about radioactive material.
Oh, no. I might have flipped the numbers. 2381 is what we're looking for.
Relating to, yeah. So can you see this one now? Yes, I think this is the one.
So what this one says, 2381, we'll go back to committees in a minute, but this one, 2381, modifies laws relating to youth suicide, intervention and prevention to include children under 10 years of age. So Oregon has a 5-year suicide prevention plan, one specific to the youth and young adults ages, they originally was 10 to 24, I believe, and they're wanting to bring that down to age 5 to 24 from 10, because we have children between the ages of 5 and 10 that have been directly affected by either suicidality and or suicide, whether it's loss, whether it's witness, whether it's suffering effects, thoughts, those kinds of things. And so this is going to expand the age that they're able to address, including school-age children in grade school. Sadly, 2 years ago, when we were meeting for a quarterly meeting of the Oregon Alliance for Suicide Prevention, during the meeting, right before the meeting, there was a 4th grader that died. And so anyway, we've also had in our previous years where people have gone to the legislature to speak specific to the topic of suicide and suicide prevention. There have been a number of children of various ages, school age and up, that have come to speak to the governor and others. and I'll never forget one of the children asking, what do I do when my friend says they want to, do something, what do I do? And this was a very young student. So it affects children of all ages for sure.
Yeah.
So anyway, this is what this bill is about. This one, it says, is sponsored by Representative Prusak.
Yeah.
So
Does
anyway,
if this passes, will then have to mean more that's going to be some cost to broaden out to the younger age groups or more prevention activities to help fund that particularly and strengthen the outreach? What is there
well, do you want to click on analysis? I don't know if they've had an analysis yet.
Yeah, I don't think so. No, they
So
haven't.
here, if they had a revenue impact statement, they would upload it here, or a fiscal impact statement. So those are listed across this bar in this, the system that we're looking at, that we're bringing you the summaries. It's called OLIS for short, and that's Oregon Legislative Information System, OLIS. In the address bar at the very top, you can see it's olis.leg.state.or.us. But if you Google OLIS, and you might want to put Oregon in there, that'll bring up this whole system that gives you detailed information on all of the bills, all of the legislators and their contact information, as well as committees. So OLIS is a huge resource, and you can watch live video feeds of hearings. You can see what people have submitted as far as testimony, and you can find the actual text of the bill that's being proposed. Sometimes there's different versions of the bill. Sometimes you see the original version, and then people add amendments as they discover maybe a flaw or an opportunity for improvement. So you'll always look at the latest version of the text of the bill if you're looking at that. Could you take us to the committees button, Kevin? And I want to show people where the committees are.
Which one are we looking for particularly? House Behavioral Health? How about that one?
There you go. So there's quite a few committees, one of which is the House Committee on Behavioral Health. So I started to talk about the role of committees, again, because there's so many topics. So the legislature bodies, the Senate and the House, their leadership, they convene and they get all their legislators together for votes. But the work on these bills is done through committee first. So the bill usually goes to a committee. The committee sets a hearing date or whatever. They read the bill, they look at it. If the bill's assigned to a committee. And so when they get a list of the bills, they'll look at it. Each committee has a chair and vice co-chairs usually, and its members. There's also legislative staff, and they'll communicate with you if you need to on information about the bill, such as when it has a hearing date, how to add your testimony or written statement, those sorts of things for these legislators on this committee to consider when they look specifically at the bill. Usually they'll assign a work session or a couple of other meetings, one of which might be a public hearing. Sometimes those public hearings are open not only to attend, but receive testimony. There's some meetings where they don't receive testimony. They say, we're just going to work on this bill. We're not taking any testimony at this time, but as a committee, they discuss the bill, and you can watch that and see their discussion and what happens in that. Sometimes even legislators show up and testify in other committees for bills that they're passionate about. So I always recommend taking opportunity to watch that. On the right here, it shows the meetings of the committee. Usually you'll see a little circle, and that's a video button, and you can replay. So one of the things that might be really interesting, if people were to replay the videos of what happened in previous legislative sessions with the bills that Drake was talking about, working on decriminalization. Several years ago, they had a committee meeting, and it seemed as though the chair of that meeting kept allowing family members to have long testimonies, like 30 minutes or so. And yet consumers that came to present their point of view and give input were told they had to hurry up and they could only have a few minutes, and they were cut short. And so a chair does have power on the agenda of a committee, you know, and so that's something to pay attention to. You know, do we feel like the people that are bringing the information to the attention of the committee, are they getting, you know, equity when they're trying to present? And if not, then that's an issue of concern. So anyway, you can see some of that in action if you replay those videos.
Yeah, one of the things that we've been told is, since we're going into this virtual, mostly virtual for except for the actual electeds, everybody else, you know, the public, the lobbyists, everybody else is going to be doing virtual, that the access to be able to just interact directly with a meeting, you know, through digital forms is going to be important and meaningful, we've been told. It'd be interesting to see, you know, this is one for me. There's two committees at the get-go that is where all the action is going to be for me as a behavioral health lobbyist, and that is the House of Representatives Committee on Behavioral Health, and then the other one, which is a new is sort of a new add-on on the Senate. We used to have, last session, we used to have a committee called the Mental Health Senate Committee on Mental Health, not on behavioral health, but on mental health. And it was a committee chaired by the outgoing Senator Arnie Roeblen. And now that mental health and recovery is folded into Senator Sarah Gelser's Senate Committee on Human Services. And so both on the Senate side and on the House side, those are going to be two of the committees that are looking at behavioral health and mental health. And as most people may or might not know, oftentimes bills will get a first hearing, you know, that relate to behavioral health. Will get a hearing on one side, either the Senate side or the House side, and then the next step in that process is it will get a hearing on the Senate or the House side, particularly, or vice versa. And so those are very interesting to follow. You're right, Laura's totally right. An awful lot of work and leadership and movement and advocacy for these things take place on the actual policy committees. Then it, you know, the treacherous step then is, even if it does pass a committee, does it get through the multiple channels of the Ways and Means subcommittee and into the Ways and Means, and then voted on the House or the Senate?
So that's what happens if the bill has a financial impact. If there's going to be cost involved, money involved, then it gets referred to Ways and Means, who's, you know, not only was it decided as a, you know, important, effective piece of policy, but then does it fit within the budget that they end up having at the very end of their session, called the legislatively adopted budget, which is what the agencies have to work with over the next 2 years in our biennium starting July 1st. So yeah, that's a big piece right there.
Yeah. Okay.
Otherwise it goes to the full legislature, like the Senate or the House, and then they have to have it. Don't they have to have it 3 times? It's read 3 times, and then it is voted on for a pass.
Yeah.
Pass.
Now, some bills may start in a behavioral health and then end up in. So it was interesting because Senator Gelser said that maybe some of the bills that float relating to behavioral health and judiciary may end up also getting a hearing in her committee, which I always thought it was somewhat backwards that the policy committee on health or health committee, if they wanted to make a law change, I don't completely understand how that process works, but whether some go to judiciary, if it's going to change the law, or whether they have to weigh in on it, or they also start there or whatever, I'm not sure. But anyway, so that's very good. Do you have another one we could spotlight?
Yes, I thought I'd also like to spotlight HB 2315.
HB 2315. Okay.
Yeah.
I want to say, thanks so much to Laura Rose and to Janie and to Drake for all joining on this. This is something that we, Facebook Live is free to do this. We've never done this before, and I'm glad we're taking a shot at it. So you want me to read the summary, or do you want to?
No, I'll just read it. So this one, it says it directs the Oregon Health Authority and specified professional regulatory boards to require licensees regulated by the authority or board to complete 6 hours of continuing education related to suicide risk assessment, treatment, and management every 6 years. So 6 hours every 6 years, and to report the completion of continuing education to the authority or the board. And so one of the things that's been going before the legislature for a few years now is this, request and expectation that certain professionals would have the training for the suicide prevention, assessment, treatment to understand. And then, at least 6 hours. We've heard that there's people that went through medical school and other professions, and they just have next to no training on suicide. We've heard from counselors that say that the only training they got on suicide prevention was that you have to be very careful for liability concerns. So protect yourself, so to speak. But we need people who can treat people that are suffering with suicidal urges, intrusive thoughts, attempt survival, loss, all of that. And so it's unfathomable to me that these professionals in healthcare have so little training. And some of the larger organizations, such as the Oregon Nurses Association and the Oregon Hospital Association, possibly some of the physician organizations, seemed resistant to having a requirement for this type of training when it's such a huge health issue in our state. We lose so many people every year to suicide. It should be treated like I don't want to call it a pandemic, but it's its own health crisis. It's a huge issue. I don't know why we don't do more about it. Anyway, so we're asking for folks to have training on it. Now, one of the areas that I was looking at training quite a few years ago was in the traditional health workers. We had 80 pages of all the requirements of what the curriculum and the training should look like for an 80-hour training for peer support specialists and peer wellness specialists and our other traditional health workers. And there was only one line in that entire 80 pages to handle and have training about crisis. And to me, that's hard to believe because it's a big factor. It comes up a lot. I work with lots of nonprofits, including some of our community-based organizations. We have organizations like Project ABLE, Recovery Outreach Community Center. We have other organizations. Youth Era has a number of what they call youth drops, drop-in centers, so that people can go in and find a place where they can get peer support, they can engage in activities, they can find healing and support for their recovery. And what was happening for a long time was people were some people, I kept getting reports from people in the community, they would call the suicide prevention hotline, and they were told if they had called there before, it was like it wasn't emergent. And so, these lines were reserved for people that this was like their first time and it was an urgent situation. That's no longer the case. We've met with them and now they have more comprehensive services. However, what was happening was the peer-run organizations would get calls or walk-ins with people in suicidal crises saying, I've already tried to call the suicide hotline and they won't help me. I need help now. And so we had peers that didn't have training, that weren't equipped with the information to be able to feel confident and know how to respond. So making that a piece of continuing education so that there's at least a bare bones understanding. I think that's really important for all of us in behavioral health and even healthcare in general.
So I appreciate this and this initiative and this bill, though I do think the devil's in the details. A suicide risk assessment I don't see like a lot of controversy or disparity of opinion around that. But the next point in this regard, continuing education related to suicide risk assessment, treatment, and management. The two other ones, treatment and management, who decides what is on the plate about that or not. And I just put in the Facebook chat the homepage for Eduardo Vega's Human Innovations, and some of his approaches to understanding suicide and suicide prevention. And I fear that once again, that those two second parts of this, treatment and management, regarding this issue, will be dominated by by the industry. And I don't think that serves us well to have one particular point of view and not hear from peers or survivors themselves who are running progressive or have a little bit different take on some of this sort of stuff, and that worries me.
Mm-hmm. Well, these are really great things to bring up. I would encourage people to, think about submitting testimony related to this bill, addressing it to the chief sponsor, Representative Salinas, and to the chair of the committee that it's being assigned to, for sure. I do agree that it's important to have, the information be informed by people with lived experience who are the experts on surviving and coping with and getting through and experience, what the impact is and all of that, and making sure that when they talk about treatment, that they're, not just a one-way fits all, but that it is responsive and individualized and self-driven, that there are alternative modalities that work better for different people. And also the management piece. I think the risk assessment piece, so it's a big thing to understand the difference between somebody who might be saying, casually, I just can't take this anymore, versus, people, we know that some people have more specific, maybe plans, access to lethal means, other kinds of concerns that may make it more or less likely. And so, depending on the nature of what the individual is expressing and experiencing and verbalizing, involving the individual, principles of making sure that the individual, nothing about us without us. So if somebody's gonna, say, let's make a call to your emergency contact or your favorite support person, that they're doing it with the person, that's much more successful and inclusive generally. There's some good principles that could be definitely discussed and advanced. I'm not an expert. I'm not a clinician. I'm not telling people how to vote. I'm just sharing kind of what the background of this particular bill is and some thoughts on it.
Very good. I do have a question, and maybe why don't you take 2 or 3 minutes and tell us a little bit about 988 and what that means for folks, regarding suicide, and also if we both serve on the governor's task force of 988, and maybe take 2 or 3 minutes and explain to us what that is, and I'll be right back.
Sure. So we have 911 in our country to contact emergency response, the police generally, and often as needed, fire and or ambulance for emergency services. But oftentimes, if people are having a mental health struggle, they need to be able to get in touch with somebody right away that they can talk to, and or if it's a family member or a friend or somebody that you're concerned about their safety and their health and all of that, do you have somebody that you can reach out to, both for support and maybe some guidance on how to best help the person that's experiencing this? And so 988 was talked about at the federal level, and then it passed, I believe, in a previous session. And so now all the states, including the state of Oregon, are looking at the implementation timeline to add 988, where you can pick up the phone and call and say, I have an issue or mental health crisis happening, please help. And so working with folks like the National Suicide Prevention Hotline and law enforcement, there's many parties at the table having conversations about what 988 will look like. I think the timeline for its implementation is anticipated in 2022. As Kevin mentioned, there is a committee that's meeting or an advisory group meeting about 988's implementation. They just had a kickoff meeting last week, so we'll learn more in the time that's coming up. One of the questions I asked, is this going to resemble, if somebody calls, is it going to look more like a dispatch call, or is it going to work more like a support call? And I couldn't get a real clear answer right away. So a couple of people said that they're going to communicate on the national level and then get back to me.
So a dispatch call would be like calling 911.
Right. 911 could send out, police or whatever, but there's been so many cases of death by cop. It's even written in one of the legislative bills that are being proposed, whereas, there's been so many poor outcomes, and law enforcement aren't trained to be social workers necessarily, so when they're responding to a call, they're trained a certain way. They have a different approach than maybe a peer specialist and or a social worker or somebody else. Now, they do have these mobile crisis teams that are getting a lot of press nationally. The one in Eugene, Oregon, CAHOOTS is what its abbreviation is. There's a legislative bill, in fact, for both looking at CAHOOTS model and coming up with a state strategy on mobile crisis with a report. And then there's also supposed to be funding for one full-time position and a $10 million budget. So anyway, will it be dispatching mobile crisis teams? Possibly. It just really depends on what they decide to do and what the circumstances are. So this is an important time for consumer voice about that topic as well.
Let me ask you a question. So in that Mad America, I posted it to the Facebook chat around suicide hotlines bill themselves, I'll bring it back up, as confidential, even as some trace your call. And if you read this, there are people saying they call the suicide helpline for help, and that people got involved and people ended up losing their jobs and then ended up suffering a certain amount of discrimination because of the lack of confidentiality. Where is the suicide, the lead people who lead Oregon around the choices around suicide and suicide prevention campaigns? Where are they on this sort of thing? If a viewer called the suicide helpline in Oregon, would they be able to find out their phone number and their address and require that the person calling the line for help give that information, or do they have a caller ID, or where is the boundary between invasion and public safety and consumer choice around what we have in Oregon around suicide helplines?
That's a great question, and I don't know all the answers to that. I do know that when people call the national hotline, the 800-273-TALK, when they call that number, it routes it, I believe, based on the area code of your phone number through caller ID. And so if you're in most of Oregon, I believe it gets routed to the Lines for Life, which is a nonprofit, and they have volunteers and they train people to answer the calls. There's another group, Northwest Human Services, that's in Marion County, and it may cover 1 or 2 or 3 counties. And so depending on the area codes, again, it goes to, those are the 2 groups that at the last meeting I heard confirmed that they're the ones that are responding to those calls. In addition, my understanding is each and every Oregon county is required to have a crisis line available for people that need it, especially members of the Oregon Health Plan. who have the public health insurance and may be receiving mental health services. But that's a different system than the Lines for Life. So depending on what number people call, but the main number there it is, 800-273-8255. If you call that number, then it goes to Lines for Life. I think if somebody says, help me, I didn't mean to do this, I just did something and I'm afraid I'm gonna need to go to the hospital, or if you can't even speak that well, then you might give them cause to say, hey, this is an emergency. Let's get, emergency people to the house of this person. I imagine they would ask you to give your address information, and if people don't feel comfortable, they can always hang up. I don't know the extent of their call tracing, though. That would be a question for them.
Is there, I haven't really looked into it. Is there a lot of research on the value and the merit that these actually save lives and get people connected to peers and helpers? And I don't really know, because I haven't really looked into it. Though I have called these helplines, or something like it.
I hear a lot of people say they'll never call them again. They'll never trust them again. Somebody came to their house, police unexpected, and that caused issues. I mean, so there's definitely some, concerns about the outcomes that, maybe the person on the phone didn't have enough training necessarily to make the right decision. Although I do know they tried to provide them support and supervision. These are individuals that are volunteers that are doing their best. They may not be, full board clinicians per se, so it's difficult to know. I don't know if we're comparing apples to apples or apples to oranges if we ask, if one helpline is helpful and another not as much. On the other hand, I've heard people say they absolutely saved my life. If it weren't for them, I wouldn't have gotten through this. There's some interesting suicidality support groups happening in our state. And there's one gentleman, and he's been getting his group to go together on bridges in Portland and put these like Ziploc bags up with these kind messages and or phone numbers for people to call, and just to write a note that says, I care about you. I really hope you don't, do anything you would regret, basically. And so people are motivated to help one another in any way they can. And I see a lot of people, that's why they're volunteering for these helplines, is to help other people. So.
Yeah. Well, I appreciate that people out there, and that I think that we've reached a critical mass where I think all society understands what a epidemic we have of around this issue, and just the particular.
Can I mention something also?
Oh yeah, go ahead, Drake. I didn't know you were there. Go ahead.
My phone is holding up. I think one of the parts that doesn't really get mentioned, a lot of the people making laws and policies and rules, and even the schools that teach people how to do counseling and crisis work and everything else, don't really take into account that there are some people that are good at it, and having a degree or even the training doesn't necessarily mean you're going to be a success. The difference in most crisis encounters that I found, and I've actually worked on Whitebird's crisis lines at times in my past, is that some people are good at it. Some people are good with some people and not good with others too, as well. It's really a human resources issue rather than a training issue. I mean, there are people that really should be doing those jobs, and there are others that will end up with people not ever calling them back again, partly because they lack. It's one of the interesting things is a lot of the crisis counseling will teach people not to actually take an interest. I was on the Whitebird line one night, and they said some guy called in and had terminal cancer, and the guy that it was an overnighter, and the guy that I was working with just wanted to go back to sleep, which they let you do as long as you answered the phones because there were long shifts. And he took no interest in it. And so he did a bunch of reflection, tell me how you think about, tell me how you feel about that and stuff like that, which is a standard technique. And he didn't do anything quote unquote wrong, but he totally lacked any connection with the individual. Nobody wrote any notes and sent them. And that makes the difference. And that's one of the reasons that peer stuff works, is because there is some sort of, it's grounded in some sort of real humanity and real human interest in the other individual. And just teaching people that somebody shouldn't kill themselves is a lot easier than finding somebody that can really connect with somebody and make it so their life doesn't seem like it's so horrible that they want to. So anyways.
Exactly. I wish the script was about creating the life worth living. That's an important piece. It's not just stopping what you don't want, but how do you build what you do want? And that social connection piece is just critical.
I asked Laura about this earlier. Drake, I know that you're a parent of a teenager. The whole idea, and I think maybe our whole understanding of it needs to change, is, our teenagers and preteens use calling people on the phone for much of anything. Or, mostly it seems like the people that I know they do an awful lot of communication through, Snapchat or texting or WhatsApp or whatever. And where are we if, according to stuff that I've been looking at the last couple of months, is that the area of preteen and teen, particularly around young women and self-harm and suicide issues, has just been skyrocketing, 500% since 2007 or 2008, I can't remember. But where are we with these so-called helplines that provide technology that young persons are comfortable using? Maybe it's easier to text about some issues, for privacy, or, for some greater sense of anonymity, or, whoever else is in the room, like your teacher or whatever. I don't hear much about, I hear about, suicide helplines, which I think is a telephone number, but I don't hear much about other projects, particularly of young people around that.
Yeah, and in most cases, I would hazard to guess that these things are end situations rather than beginning situations, and there's not much orientation towards being proactive. Like in my particular case of my particular daughter, because she found out late that I was her father, and she was in a home that wasn't really safe, and she got taken away from her mother by the courts. And I knew that was going to have some huge impact, as well as the situation she already been in. And rather than just wait till that turned into some horrible crisis, or have her be assigned to somebody that I absolutely didn't want her stuck with, I took her to an agency that I trusted and found somebody that I thought wouldn't try to just drug her and would listen. And that's actually worked out pretty good.
Oh, that's such good news to hear.
That is good news. Yeah.
And I don't have a whole lot of trust in the system, but if you set it up with, there are good people in the system, and good people can have good results in a bad system. But the trust thing and finding a way to get in contact with somebody before you're ready to, do something horrible is really important.
Yeah.
Definitely.
So
well,
Laura,
one thing I will say is if you take a look at the Youth Line website, I just had a conversation on Friday with Lines for Life, and I said, your website doesn't give people, reassurance, like an expectation, what's going to happen if I call this number, and I've been trying to get in touch with them for 9 months to give them this feedback. And it just kept, getting postponed. And then we had wildfires and whatnot, but we finally connected last Friday. And so they're going to be sharing that information. But I said, the people working on the website and the graphic materials for the Youth Line do a phenomenal job. They hand out business cards that say, like maybe a picture of a cat or something, and it says, it's nice to feel soft things, but you can like flip the other side and it says something like, but maybe we don't feel so good all the time, let's talk. They said we keep it to ourselves. So there's just those kinds of invitational and reassuring messages right away. There's 4 different options. Do you want to chat? Do you want to talk to someone? Do you want to, I don't know, there's other modes of how you can talk to somebody anyway. So they give you all those different options on that youth line page. So it's just way more friendlier, better appearing. It can make such a difference too. So I really encourage them to revisit their adult, websites and see if they can't carry some of that over. This one more bill before we switch off of this topic, Senate Bill 682. Now there are, I think we looked up and there were 12 bills that mention suicide in their text. But this one, bringing attention to the Adult Suicide Intervention and Prevention Coordinator. So as I mentioned before, there was a 5-year youth and young adult suicide intervention prevention plan. They're working on that right now, and that's going to be done May or June. In parallel, now we're developing the Adult Suicide Intervention Prevention Coordination Plan. It's a 5-year plan. And so people are invited to join discussions that they're having right now, especially if you have lived experience, if you are in a BIPOC community, or maybe a veteran or another group that is, especially interested in this topic for adults, 18 and up or 24 and up. So the person that was hired at the state of Oregon, Deb Darmata, comes from Washington County. Washington County achieved a 40% reduction in the incidence of suicide. They did a lot of work, figuring out the touch points where people intersect when they have, a suicide plan. For example, maybe they drop their pet off at the Humane Society, or maybe they check into a hotel room, or different things. And so they've gone and done a lot of education at all those touch points. When people have an eviction served, that's one of the highest risk times. And so they've even worked with like the sheriff and the people that serve the eviction notices to have a social worker come with materials and support in the case of eviction, for example. So in all of that work, they were having success. That was highlighted by a group, Mad in America, with Oregon's former behavioral health director, Bob Nickel. If anybody's interested, there's a whole series on Mad in America about suicide prevention, innovative approaches, and we can help you get, I think, access to that. If you're interested, write us, we'll give you the information about that. But this particular bill adds some work being done on that adult suicide intervention prevention plan. And Deb Darmata from Washington County has been hired in the position as the coordinator. She's working on that plan. That's also due out in May or June, I believe. So if you want to have input, this is a great time.
So Laura, it says to hire this person, but it looks like the person's already hired. What does that mean?
Yeah, I'm not sure why it's written like that. So I'll be interested to have a conversation and find out.
So is this basically for one FTE and then for some health promotion and outreach and committee platform management costs?
I think so. I mean, if you read it, there's also a clause in here about continuing education, similar to the other bill that we looked at. So I'm not sure why they highlighted this. Maybe, I really don't know. But if you scroll down, there's some more text involved besides just that position. But you certainly can look and see what they're asking the coordinator to do. Part of that is collecting the data and reporting the data that's happening. A lot of people are saying that the suicide rate, I guess, for the first time in a number of years, may have gone down for Oregon and other states. However, people have pointed out you really have to look closely, because it has increased for certain age groups, and that kind of thing. There's a lot in there to consider. So
Very good. Very good.
anyway, thank you for that. Moving on, let's hear about House Bill 2086.
Yeah, so let me bring that one up. Part of this, part of this work that we all understand is so rich with acronyms. So let me give you a test. What does the acronym, Laura, GBHAC stand for?
Yeah, that's a new one. GBAC. Governor Behavioral Health Advisory Council.
That's right.
So that started not this last November, but a year ago, November. They started convening meetings and they had people look at past recommendations for behavioral health and then come up with the priorities of what eventually became part of Governor Kate Brown's most recent governor recommended budget. So there's the agency budgets, and then the agencies talk to the governor and the governor's office. They form the governor's recommended budget. That goes to the legislature. That's what they start with, is that proposed governor recommended budget. And then they have their own teams of analysts and lawyers and other folks that look at all of this. And then the Ways and Means Committee, and they come up with the final legislative adopted budget. So, and I did a study a few years ago when I was in graduate school, and I said, how has the difference changed over time? If you look through all these years, what do we start with in the governor's recommended budget? And then how does it turn out in the legislatively adapted budget? And you could see the trends over time very consistently. Public safety usually is always higher in the legislative adopted budget as a spending category compared to in the governor recommended budget. Often education, the same thing, often ends up at a higher rate than originally recommended. Other categories tend to have less. So anyway, I was surprised they hadn't looked at that report themselves when I asked about it over at Department of Administrative Services, but definitely there were some interesting highlights.
Yeah, so more about this governor's council. So and I know that there was a legislator named Representative Mitch Greenlick, and one of the last things that he did, well, two things that he was working on. He was working on the Behavioral Health Roadmap Commission that was going to take a decade-long look at the entire provision of behavioral health services in Oregon. And that was one of the things I was very interested in. And some of the initial homework he did around that was he tasked the governor's behavioral health administration and their health authority to tell them how many boards, councils, committees, and advisory processes do you have related to behavioral health under your bureaucratic umbrella. And am I right with that, like 42 Yep. or 43 or something?
Yeah, the count was in the 40s, and then they've added several more. Sometimes I hear people go, oh my goodness, another advisory committee, but there are quite a few.
So one of the things that's very interesting, so myself, I got appointed to this council in October 2019. And one of the two things that I was very interested in learning about, if there was going to be 35 people at the table, and we were talking particularly about behavioral health, how many people at the table had lived experience? And what I mean by that is how many people who actually had received behavioral health services as a customer of the state of Oregon. And I was very interested in that. And then also too, do we have adequate representation, from the Black, Indigenous, and people of color communities, and raise those issues early on. But the other issue that I have some regret that I didn't raise early enough, but was the issue of we have, and we have significant councils under behavioral health that do these processes, that make recommendations. And one of those is the Oregon Consumer Advisory Council. Why don't you take 2 minutes and tell us what that is, and why fundamentally they should have been folded into that from the get-go, if you want to give us some pieces of that. I should also say Laura is the chair of the Oregon Consumer Advisory Council. I'm going to bring that up, Laura, so people can see that page. Like, go ahead.
Sure. The Oregon Consumer Advisory Council, it advises the Oregon Health Authority on issues of behavioral health. So addictions, and that includes gambling as well as substance use, also mental health, trauma. Trauma and mental health are very closely related, but sometimes there's some nuances with the recommendations. And on that council, Oregon Consumer Advisory Council, we have subcommittees. And so every year there's a planning meeting and all the members get together and they talk about, what they want to focus on for the next year, where they're at with work they were doing in the year prior. Sometimes there's some carryover work. And through those committees and through that work, somewhat similar like with the legislature, if a recommendation comes out of the committee, it goes to the full council. And then if the full council is in agreement and supports the recommendation going forward to the Oregon Health Authority, then we submit that to the Oregon Health Authority formally in writing, and they have 60 days to get back to the Oregon Consumer Advisory Council with a response. And so there's a lot of topics that are addressed on the council. Our committees right now include trauma-informed systems, the tools, technology, and access committee. We have peer-delivered services committee, peer support committee, they're one. And then we have the development and membership committee that deals largely with the operations of the committee, recruiting members, supporting, giving mentorship, those sorts of things.
Very good. Oh, go ahead.
Yeah, here's the web page for the Oregon Consumer Advisory Council. So you should be able to come to this web page and find the meetings, current meetings, past meetings. Sometimes they don't always update it as fast as we would like them to, but we're working on that. So if you ever have a direct question, there's a phone number to call, an email address here. Bo Rappaport or Brandy Hemsley, either of those people can be contacted and give you information on OCAC. Kevin is our vice co-chair, and he serves along with Chrissy Parasol as vice co-chair, and I couldn't do the work without their leadership and assistance. And we have a great council with many people from all over the state, different stages, different ages, different histories, backgrounds, and perspectives, different cultures. And so we all come together every 2 months, 6 times a year as a full council to work together and bring issues to the state. And the state also comes to us for input. So we meet with the behavioral health director, Steve Allen. He's been attending the meetings. Deputy director or chief operations, Kylene Zimber, she comes. Annalise Dolph is government relations. So she comes and talks about what's happening at the legislature and the impact with that. The way that the Medicaid dollars are spent and other buckets of money, what the needs are, a lot of these concerns and issues are brought to their attention, and we have deep, meaningful discussions about them. And, that's an important discussion that takes place every 2 months.
So is the Oregon Consumer Advisory Council recruiting, doing outreach for new members, or we will be soon?
We will be soon, absolutely. We're looking for new members. We were going to have, we had membership recruitment started. We were doing it between August and September so that when we met in October, we could recommend new members. We had the wildfires and there were some other situations that put that on delay. So our new timeline, we're planning to meet in February is our next meeting. It's a public meeting. Anybody's welcome to attend. And then in the April meeting, we want to be able to recommend new members. So between February 10th, I believe, and April 10th, somewhere in that 2-month time window, we will be asking people to consider submitting an application. There's going to be an information and sort of like a question and answer period set up at a 6 or 7 o'clock meeting on the March 3rd of this year with Brandy Hemsley, myself, and probably Kevin and others to share a little bit more about the process and the council answer any questions. And so it's usually a 3-year term. So it's a commitment to attend these meetings. You can attend by phone, by video. Hopefully, again, we'll be attending in person. Great opportunity for networking and getting important work done in our state on behavioral health with the consumer and lived experience perspective.
So thank you so much. And thank you so much for your leadership of that council. So one of the things that differentiates the Consumer Council from other boards and committee work particularly is that it is in the state statute. And so what that means is that the legislature formed this council and exists by state law. Is that right, Laura?
Yes.
So an administrator who says, I want to
Drake
front
was a part
load.
of that history too.
What's that?
I said Drake was a part of that history.
That's right. That's right. Drake, are you still with us? Drake Eubank is on our council as well. He might have got disconnected, but one of the things that is interesting. So
I'm here.
There
yeah.
he is.
So one thing I'd want to say just about a new administrator gets in there and thinks my job is just to serve industry and just hand over more buckets of cash to them. And we got to get rid of these pesky consumers who are, trying to realign some of our product or whatever. They can't just with a red ink pen just redline this council and make it go out of business. I mean, we exist by state law. This legislature created us and the governor signed it into law. So that gives us a sort of sense of security and a formality for our voice that I think that people should know about, which is one of the highest things to be in the law. Makes it a pretty secure council and means that the legislature finds this a very important council.
Kevin or Laura, Rose, or Drake, could you talk about some of the impact or issues or topics or even programs and services that have been changed or advocated for through OCAC and your work?
Sure. Maybe Drake could speak to that first.
There was something called the 1% Initiative, which was interesting one time. That was unanimously adopted as a recommendation, but unfortunately didn't go anywhere. But 1% of all the mental health dollars for Medicaid and the block grant to go to peer-run services. Over time, I think recommendations have usually taken the form of trying to get peers included under existing authorities, and it ended up being kind of a battle with different administrations as time went on. To be able to run down all of those policies, I'd have to have some paperwork and documentation in front of me, so I apologize. And that's it's generally operated as a discussion forum where there's direct dialogue. And I think a lot of the funding for the state support of the peer-run programs and training certainly have really kind of been filtered through there, even though the enactments were actually through staff.
So
That's all I got for now.
We did a set of recommendations in January a year ago for 4 things that each of our committees wanted to see come to fruition. One of which was peer respite, one of which was peer telehealth, one of which had to do with standards for peer delivered services, Do you remember what the fourth one was, Kevin? Trauma-informed approach. I know there's a recommendation for a coordinator for trauma-informed care at the state.
That's what it was.
The state's working on having sort of their culture be transformed to be trauma-informed. They feel like they need to work on having their culture with those values before they, extend that with authority to other agencies and providers and contractors, I believe. I mean, I think it's a system change that, they see it taking place step by step. When you do systems change, especially for real people, employees, like I'm sure Janie knows, if you're doing too much change constantly 24/7, people get burned out. They have to have some time to adjust to the change, get used to the change, then take the next step, with a little bit of downtime. Otherwise, everybody's going to be burned out in the workforce. So, so it's a process for sure. But that's been a huge effort that there's been a lot of interest. When we started out, it was, I think, like trauma-informed committee, and then it changed and it transitioned. They said, no, we want trauma-informed systems. I've long advocated that the care shouldn't just be trauma-informed, it should be trauma-free. But some people feel like it should stay trauma-informed care as the name. And so that's how it's currently going forward. But yeah, we have very rich discussion on what that looks like in different aspects of behavioral health. There was a lot of attention brought to parity issues, so that you have the same level of service, whether it's going in for physical health or mental health, whether it's for addictions or for mental health, whether it's for gambling addictions or substance addiction, so lots of conversation on the topic of parity as well.
We should say that just an outside point of view or a community member's point of view, the council has suffered somewhat from benign neglect. And I don't mean to say that in a negative sense, but the sense that we've had so much turnover in the leadership on our behavioral health division at the state of Oregon, and individuals who start a job who have the learning curve to learn about 15 managed care organizations, 36 counties, the state hospital system, the huge community mental health clinics, the Medicaid system, et cetera, trying to understand and be connected and keep relevant with what the council, the Consumer Council's goals and recommendations are, is an ongoing process. But I will say, we should probably also move on to the GBHC after this, but I will say the leadership of Laura Rose in the last 20 months of that council has helped us to align our calendar with the bureaucracy and their calendar of getting ready for what do we want to recommend to the leadership to ask the legislature to buy for us in the next session. And one of those sort of things that we put together last January 18th was peer respite. Now, unfortunately, when I was talking about GBHC and why did we need one of these, why do we need a governor's behavioral health council if we have an adult council, we have a children's council, we have a consumers council? Theoretically, if all of those were running on all four cylinders and connected up to the pipes and inputs of the decision makers and felt like the work they were doing was relative, meaningful, and respected and taken a look at, maybe we would have never had a governor's council in the first place, or maybe we would have had a governor's council that was more tightly connected to those as repositories and as being able to populate the work groups and the committees that council, the governor's council, put together. But there's also other reasons why people put together councils and put their name on it, especially when they're leaving office. And
can I add one more thing on the OCAC part before we turn the page? So one of the things you mentioned, we do have several different councils, one of which is AMPAC, Addiction Mental Health Policy Advisory Council, CSAC, Children's System Advisory Council, and others. We do have on our council liaison positions that are on other councils that can bring that information back. And one of the accomplishments we worked really hard on was to create, now others had started before us, so we built on their efforts. We didn't single-handedly bring this about, but we did help bring the realization of an Office of Consumer Activities to the state. And so Brandy Hemsley is director of the Office of Consumer Activities, and she gets to attend meetings as a member of their leadership team at the Oregon Health Authority. And so that has opened many doors, and she's a representative internally as a person with lived experience. Originally, that was a position filled by Mike Hebachuk and Noel, I believe, and then there was Libby Rascon. She's now in the Ombuds office, the Ombuds Advisory Office. So there's an Ombuds person. If you have issues and you're an Oregon Health Plan member, or you're helping somebody with the Oregon Health Plan and they're having an issue, you can contact the Ombuds office. And Libby is like the key person for mental health issues. She's working really hard on that in particular with the rest of their team. Luckily, one of our recommendations was to expand that team. The director of the Oregon Health Authority did that. Patrick Allen, when he came in, was one of the first changes he made. So now there's a robust team to help troubleshoot issues, grievances, concerns, and that can be really key when you're trying to problem solve. So anyway, those are some other sort of pieces of the work of Oregon Consumer Advisory Council that have been so important to improving our state. So I'm looking forward to what our new applicants are going to bring to the table. I really hope people consider applying and spread the news. Thank you.
Very good, very good. So the one last thing that I wanted to talk about was the Governor's Behavioral Health Advisory Council and the work of its committees. And Janie, thanks so much for joining us again. Why don't you start us off and talk a little bit about your experience of interfacing with that work group, and then we'll go from there and highlight a few things in that bill.
Sure, thanks, Kevin. I was part of a subcommittee, so not the core group, but I did appreciate the seat at the table. It was programs and services. I don't know, I can't remember the official name of the subcommittee, but my experience was there was a wide variety of leadership across the state. On that subcommittee, we had key areas brought from the larger group that we discussed. I apologize, I don't have that in front of me, and it's been, I think, over a year since I was a part of that. But I just printed off the governor's, the whole, there's 19 pages, 38 total, I think, front and back of the work of the entire committee.
Did we mention the 3 subcommittees: workforce, housing, and programs and services? Yeah, there was a lot.
Good. Yep, programs and services was the one I was on. But the key points I think I brought, and the soapbox I was on, was peer services at every aspect or potential intervention, or even without any other interventions, but making peer services available, peer respite, of course, and then places where people can unprescribe or de-prescribe with medications, especially when they've maybe moved or had multiple prescribers, and the quality of life issue that was mentioned earlier in this conversation with those first 2 Senate bills we talked about. Just there's no place where we can go and be supported in exploring what mental health recovery looks like for us. And so, and it seemed well received. And like I said, there was several different leadership across the state and different systems that were there, and there were a lot of head nods. So we'll see if that actually went anywhere.
So the formal council started in October. When were you invited to participate on the program and services work group or committee?
I have memories of like February and March.
Thanks, Laura Rose, because it all
A while ago.
It was when we were able to meet in person. I know that,
Yes.
and multiple meetings, so it had to, yeah, it was definitely before March.
Then everything went online.
Did you, Janie, come to that with an agenda, like you wanted to see this past the finish line? You wanted to be able to move this, you know, whether it was open dialogue or peer respite or more general funds for peer support services? Did you come with something like I want to see this past the finish line and move into the final bill that we're going to look at in a second?
All peer respite, it was at the top of that list, and will be until we see an actual true representation across the state of support, and then actually get some peer respite up and running, peer run respite up and running.
Yeah.
We were able to look at some other states, and New Hampshire has been a leader. They have the contracts for the peer operated respite, really spelling out some of those finer details. And so I've shared that with our leadership. I hope that'll be, you know, something they can follow the model of.
One of the things that struck me, and you've heard the term climate deniers, though I don't use the term trauma deniers, I do think that there's almost a knee-jerk reflexive sort of sense that people will acknowledge that their treatment or the experience of someone they know had been traumatizing, or that individuals had come from traumatic backgrounds. I still think that Oregon behavioral health leadership, particularly in industry, has a hard time coming to reconcile that some of the things they do may be counterindicated and may actually continue to hurt and traumatize the person who is looking for help and support. And I appreciate that people talk about it, but when we look at some of the systems and some of the recommendations and some of the things that people were talking about, it still made me wonder. I don't think that we, as a entire behavioral health field, have acknowledged that to the degree that I had hoped for. And also, we started out this discussion about civil rights and those two Senate bills that Senator Brzezinski's and Judiciary is pushing. Still, I don't think that people, and one of my biggest challenges in dealing with industry or the big insurance companies is that we have it's not like the VA system, like the guy in Washington, D.C. who runs VA is the same employee who out here, who's the VA is doing peer support for somebody here in Portland. They all work for the same system. And in here we have helplines that come from one nonprofit. We have treatment that comes from another CMHC. We have support services and some of those other things at other places. And so many times I think is that the challenge for behavioral health is not when you're in front of a provider or a person with resources, it's in between the gray areas or the cracks in that where they're warm handing you off. And I think what I certainly believe is that if we had a peer services support, as an entitled benefit that was actually above board, and that people were educated the first time they walked into the door or called a helpline of why is this crucial? Why is this important? Why have other consumers found it to be a very important, lifesaver or meaningful connection to an otherwise, bureaucracy of, 1,000 people. And I think sometimes that although there's people pay lip service to it, I don't think that we have forwarded that enough with our pocketbook and with our choices at the top. So let me bring this, Laura Rose, any other reflections on your work on GBHC? One of the things too is that I wanted to say, and I regretted it, I should have raised it at the beginning or as soon as on January 18th, 2 months into the council, I wish that I would have taken our Oregon Consumer Advisory Council, those 4 recommendations, and said, by the way, I think we need an education to all 35 council members about what the Consumer Council is, about what the Children's Council is, about what the Adult Council is, and to look at their work product over the last 48 months, 72 months, because there's an awful lot of people on those councils who feel like we're an ongoing process, and we have moved forward recommendations that have either remained unanswered, or for some reason we didn't get them synced up with their timeline, and so they were not valid or not relevant until, you know.
I've been recommending a dashboard that would show, you know, we've made these recommendations, and then here's been the outcomes of those recommendations. Here's the different committees, who's on which committee, who's the chair of the committee, where's the webpage for the committee. And so that is something that we're in discussion with Steve, Alan, and Brandy to bring about. You know, right now they have priority with the vaccines and many other hot topics and the current legislative session. But I do think that could wrap into some of that planning work you're talking about, that roadmap work that Mitch Greenlick was talking about.
Yeah. So let me read this. So this House bill was put together, and not all the recommendations that the Governor's Council put together made it into this, but a lot of them did. And so the summary is this appropriates money to the Oregon Health Authority to undertake specified steps to address needs of individuals with behavioral health disorders for services, treatment, and housing. Declares emergency effective on passage. So if you roll down into this, and one of the things that I thought early on, my question to Janie, whether she came to the table thinking we need to bring open dialogue to Oregon or something like that, is that and I told people from the very beginning, is that the thing that I have been so focused on, because it so impacted myself and it has impacted my lifetime partner and impacted so many other people, is the interspace between at your house, whether a police or a mobile crisis comes to visit you, and the coming to the psych ward. Somewhere in between a case manager or a crisis worker or a police intervening at your house after hours or being at the psych ward, what is in between those steps? And what I like to, somebody else's term, is voluntary intermediate supports for people who are experiencing a psychiatric crisis or an extreme mental and emotional state. And I've so believed in that. I've actually 20 years ago, Governor Kitzhaber gave me $5,000 to fly out to New Hampshire to look at a project that the state of New Hampshire was working with a group called Stepping Stones, and their look at what peer respite could be and what a model that they had just set up. And so we had learned through the work of Sharon Keene and Bronwyn Franklin that when their research was conducted, there was 33 or 34 of these happening across the nation, and more in plans and development. And this was something that I came to the council saying, I have eyes on one project, and I'm not going to support and put my energy to other parts of this project unless I feel like we get equal time to at least educate people of the value of intermediate voluntary supports for people in psychiatric crisis, i.e. peer respite, and why that's meaningful. And so if you look at this bill under programs and services, it talks about designing a statewide crisis system. It talks about support for early assessment and support, which is a young adults program, a young persons program. There's some money in there for some tribal stuff, some continued funding for certified community behavioral health clinics. But the one that is the most meaningful to me is a pilot project to operate 3 non-clinical peer respite centers, the back end of this is something that Oregon, that we've been attempting to educate Oregon about, on and off for the last 20 years, of why this is meaningful, why this is valuable, why big states like Ohio, California, and New York are doing these things, and why they find it that has merit. And so so if you ask me whether I, as a lobbyist, am completely excited about the fine print and about an awful lot of these projects, I'm not sure about that. But one thing I'm sure is that the people that I was on the council supported peer respite, and that when we got the opportunity to educate them about that, they became instant fans of the idea. And so I hope I have one hope for this legislative session is that HB 2086 passes to the finish line, because of what that will mean for people in psychiatric crisis, the opportunity to give a narrative, because no one's telling a story about what intermediate voluntary supports meant for them in psychiatric crisis, because it doesn't exist. It's and so much essential is riding on being able to tell the story of what happened when we had another place in between the psych ward and home when we were in psych crisis, and also the ability to take management of one's own symptoms and choose a path for oneself that's not mandated either civilly or through the criminal courts. So, Laura Rose, Janie, do you have anything more to say about this, about the GBH HB 2806? Also, too, is one of the things that I really hope for, and I was telling Laura, if peer respite passes, if this initiative passes, and you haven't seen the fine print of what that actually looks like, but I really think that the state of Oregon should designate that the people eligible to apply to provide peer respite are peer-run organizations. I really twice in putting this bill forward in the state legislature without we've had to recorrect their language of making this into a medicalized facility where they bill Medicaid and hook up to one of the CCOs or one of the CMHC's funding processes. And that's not where we are with a pilot project. This is a small pilot project to look at the efficacy. What does that tell us about people in crisis? And ideally, would it make sense to bring this into all of our major counties around Oregon? And I certainly think if we do it right, I think the answer will be certainly yes. But anyway.
I just appreciate, Kevin, all your years of advocacy for this, and just really hope that this legislation and the funding behind it, that it's not just something that passes in theory, but that really gets put into practice. So,
well, one thing's for sure, we've had 4.5 years, 5 years of educating our state, our leaders in our state legislature and healthcare and behavioral health about the meaningfulness of this and why this is so essential. I mean, if we had peer respite 10 years ago, I would have been a customer of it. And or maybe 15 years ago, and what could that have done to the calamity and the crisis and the impact of my living situation, my relationships, and my trust, with the rest of the system had I had such an opportunity. And I really think that if the reason why we decided in 1994 to start experimenting with managed care and to fold behavioral health into it under the Oregon Health Plan, which I was told, what was that, 27 years ago? The reason why we're doing this is because as we put mental health under managed care, that we will be able to do much better job of delivering care in the community and managing the most expensive parts of behavioral health, which are psychiatric hospitalizations and pharmaceutical medications. Though I'm still at a loss 27 years later to see what that campaign looks like to keep people out of psych hospitals, because if there is one, I have not heard about it. And I know that Legacy, Unity, Providence, and Cedar Hills are almost always full of capacity and people waiting to get in. where is the campaign to redirect and to meet people's needs in the community or in a voluntary sense? I'm not sure where that is. Maybe I just haven't been told about it. But. Laura Rose, you have anything else to say about that? Or
I'm sorry, I had to step away for a minute. I just got back. So I missed what you were saying for the last 5 minutes, probably.
I was just trying to make sure that Janie understands why peer respite is so meaningful to me personally. You know, I don't know if you guys ever watch late night TV, but there's a guy called the Hair Club for Men. Have you ever seen that? Well, it probably doesn't apply to you guys, but anyway, he goes on and he talks about these nylon implants, but he says, not only am I the president, I am a customer. And then he pulls his hair back and you can see it. He's got this nice nylon weave or whatever that is. Yeah. So not only am I, one of the band members pushing for peer respite, I would have been a customer in the past. Maybe, I hope I don't, but maybe someday I may be a customer in the future. And for somebody who abhors the clinical psychiatric ward and the austerity of it and just the lack of warmth and the sterility of it, I find the appeal of a peer respite and meeting people who are fellow travelers in, having behavioral health challenges has changed my life. And over again, I mean, even if we stood up at the governor's council and looked at the consumer and peers, who here has been through the process who will testify that the way that the dominant system has done stuff created our recovery? So many of us patched together or found a secondary or a less traveled road, but are here to tell the tale. Where the people who are coming out the other end of the giant dominant system and the industry run system, where are their successes? I'm not sure, because we don't hear from them very much. Maybe they're moved on, so I really think that peer respite is a lifesaver, because relationships and community are what saved my life. So anyway.
Here, me too. I would add about the peer respite, the importance, as Janie and everyone else here knows, of it being peer operated, peer run, peer directed, peer governed. There's been even studies about the differences when it's implemented by a program that's not peer run versus
right.
when it is peer run, and how that translates. So, it's coming through a system instead of peer operated. So one example I have, I know someone that had been in the hospital 18 times in 18 months, and she was offered by the county to go to a respite. Now, not a peer respite, a respite. And so what they had done is they had put her up in a motel room that was pretty, simple, sterile, plain, a set of curtains, a bed, and 4 walls. And it had a telephone. And they told her while she was in there, she was not allowed to call the suicide hotline, even if she was suicidal. And she had no peers, no peer support. Basically, you sleep there, then you come back to our office the next day. We're going to make sure you take your meds, and either send you home or decide if you're allowed to stay one more day. And that's it. And even sometimes reports where they go into the they go into a respite, and there might be a quote peer support person there. You have to be really careful, because sometimes people will write something in a grant, say they're offering peer support, but then we hear from peer professionals in the world that their hands are tied. They're not able to do the peer support that they're supposed to be able to do by way of having that position. And so some have been instructed reportedly to have to basically sit there and read a book, but don't talk to the person that's here. You leave them alone. You don't talk to them. You're just there just to be there, and that's it. Contrast that with going into a welcome place that people offer some hospitality, and they say, do you need to go, we can do a couple things today. We can either take a walk at the beach, or take a walk in the neighborhood, or we have some movies or something. I mean, there's a lot of things you can do for somebody that's in distress. Sleep is very important, but they have to feel safe. They have to feel like they can access help. And so those are like skewed versions of the concept.
Yeah.
That is not what we're asking for. So we try
Yeah.
to be as clear as we can. And so there's a lot of recommendation work that went into describing the culture and the environment and some of these other pieces that we really want to see wrapped into the program that ends up getting started as a pilot in Oregon. And so we hope that all of that pre-work will be reviewed and considered before it takes place in implementation.
Yeah, I was just, when you weren't here, I was just telling Janie that my hope is, and my prayer, and one of the next fights will be, maybe it won't be a fight, was to make sure that when they put out the peer respite opportunity, that it's designated for peer run organizations, consumer run organizations only. Didn't work 6 years trying to bring this pilot project for some big Medicaid agency just to hook it up to their wagon and just another project, because that would just be heartbreaking. But I don't feel like that's going to happen at this point, but we'll sort of see. A lot of that will be, what the process is when they write the administrative rules, who the contract, who the point person is at the health authority. But we now have, we have 90 legislatures. I could count 15 of them that I know personally, that I have educated with, and that I've spent consequential time talking about the crisis of seeking psychiatric crisis support, and the crisis that we have in our broken, if psychiatric crisis is a ladder, the very top rung is the psychiatric hospital, and in the middle rung is broken out. What does that look like, and why why peers are such a life changer? And I wish I had particular statistics that our friend Allie Linfoot talks about that. More people are at this point are recommending, saying they want peer support services than clinical services, in Oregon's second or third largest county. So I want to wrap it up because I wanted to end at 2. I want to thank Drake Eubank. I also want to thank Ann Casper for connecting with us earlier and giving us the information about Choice Heals and that important bill. I want to thank you, Laura Rose, my colleague and one of my best pals, for doing this with me. We have never done this before. I've never done a live stream, which is
Congratulations.
Yeah, well, so thank you.
You're doing it.
Yeah.
Well done.
And also, Janie, our fearless leader of the mental health addictions and
Association of Oregon.
Thank you. Janie, why don't you spend the next 2 or 3 minutes tell us again who you are and what MHAO is, and then tell us about Peer Apocalypse, and then we'll sign out from there, and I'll put Peer Apocalypse in that. So.
Yeah, thanks, Kevin. And again, thanks, Drake and Laura Rose. You always bring such a wealth of information for those of us who have not had the opportunity or the ability to get to know the policy advocacy and even the process for how all that works in the system, and what these bills are and what they mean to us as a consumer community. Again, I'm the executive director of the Mental Health and Addiction Association of Oregon. Big old long name, MHAAO for short, or MHAO if you want to go old school with our old acronym. And so we are peer run through and through in our organization. 99.9% of our staff identify as having some sort of lived experience in, just for lack of a better word, behavioral health, consumer or mental health and addiction issues, challenges, things like that in recovery, as well as over 51% of our board. And we have many, many direct service peer programs in the community in multiple systems. We are contracted, and so that's always a great way to provide peer services in a way that brings about fidelity to the peer workforce, so that we're we may be in the system, but we're not of the system. And then we do certified, state approved peer training and a bunch of other kinds of programs, but our pride and joy is the peer leadership conference, Peer Apocalypse. So, you know, we had our first virtual conference last year, but we look forward to hopefully a hybrid version this year for the first time. Very excited about that. A lot of workshop proposals coming through, but it's also, you know, it's a chance to get continuing education credits that help, you know, certify the peer workforce. But the main thing is that networking, that shared experience of just coming together, generally at Seaside, where, you know, it can be both a educational conference, but a respite from the work, if you will, whether that's advocacy or direct services, and then learning about innovative approaches, consumer innovative ideas for recovery or groups. There's all kinds of workshops, both during the day and then different caucuses at night. There's that natural, organic networking that's done. And then we've also appreciated when OCAC has come and been and had one of their meetings there. And so folks are able from across the state who otherwise, you know, previously wouldn't have been able to have access to one of those meetings, can be a part of it, ask questions, see how the work is done. So there's so much rich relationships that have come from that. I know attending my first one in 2013 was life-changing for me. And so I've heard that shared over and over again. So thanks for the opportunity to share about it.
Very good. So is registration open for this now on this page?
Absolutely is. And we, the workshop proposals, the call for proposals just closed last Friday. So we look forward to seeing the many proposals that came in. It is a conference that is for us, by us, planned by us. So there is a committee that that decides the theme, and keynotes have been decided. We have the Peer Leadership Award, and this year for the first time, we have the Oregon Homegrown Peer Leader of the Year Award, but we also have the National Stage Peer Leader Award. So we're just excited to hear feedback every year about how we can do things better, different, and just involve the voice of the people that matter, and that's the people that are part of this conference.
Yeah,
I'm a visual person. What color is it this year for the theme?
Yes. So it's oh gosh, I forgot what it's called, but we will have white t-shirts with black lettering.
Okay.
So
that's a flip.
Yes.
I should say that I started going to a national conference called Alternatives in 1990, and the spirit and the community and the warmth and just the characters that I met going to my first Peer Apocalypse conference in 2014, and it was just like coming home again to a welcoming community where I didn't have to feel like I was part of the unwashed or unwanted or part of the sideshow. You guys just every year just do a great job putting this together, and I know you got international participants, and just awesome. I so much look forward to when all 750 of us or whatever all be able to get back into in-person community in Seaside. You did. I also should say you did a stellar job of switching to doing virtual, through the needs of the COVID crisis and stuff like that. So, Well, thank you too. Not only are you guys colleagues, but you're just wonderful human beings. And I'm glad that you agreed to do this with me. I know that, it was sort of, the planning was sort of quick, put it together and see if it flies. So anyway.
Yeah, great
So
first job.
Yeah, well, thank you. And hopefully maybe we'll take a look at what's coming on the legislative session, and maybe 2 or 3 weeks, do another Saturday at noon, watch these bills, these committees are coming up, sort of thing, and see how that goes. So.
All right.
And also, don't forget, we put in the session, maybe somebody could put the OPLAT link for the OPLAT Facebook group in the actual thread. So people could, if they're reading the thread, they could just push the OPLAT link and take them to the OPLAT so they could join. Oregon Peer Legislative Action Team? Action Team or Advocates Team?
Either one. Action Team I usually go with because I like action.
Okay. Sure. And then for those of you interested,
And we also have OPRAT if you want to get into the rules and regulations side of things, such as once we start to get peer respite into that next stage, if it passes through the legislature and the budget, then the implementation piece. So there's OPLAT and then there's OPRAT. So
Yeah.
I'll put both of those in there.
Well, yeah, you bring up a key point. So just getting something past the finish line to get the legislature to fund it, sometimes the devil's in the details of the administrative rule and who's able to follow along and participate that and is invited to the process, that which can be an intimidating process. So anyway, okay, well, that is it. Thank you so much, you two, and Drake, if you're still on the phone. And so that's it. So have a good afternoon, everybody. Goodbye.
Bye.
Goodbye.
Okay, we're done. Thank you. How do you think it went?
Great job, Kevin. Oh my God, that was awesome.
Well, good. I didn't want you to feel like, hold on. Are we still on Facebook? Hold on.
Oh yeah, we still